Welcome back. Well, yes, indeed, they're talking about some of the challenges, opportunities, if you will, concerning the administration of the COVID vaccine in Nigeria, and particularly keeping tabs on what else is happening across the world and how it will affect our own supply and subsequent administration. We've got Dr. Simon Agwale joining us this morning. He's the chair Africa COVID-19 Vaccine Manufacturing Initiative. He's also the CEO, Innovative Biotech in the States and Nigeria. Good morning, Dr. Agwale. Thank you for joining us today on the program.
Now, good morning, and thank you for having me.
Yeah, I know you talked about some of the challenges you expect in terms of manufacturing. Where will the country get vaccine to meet up with our targets, our demands over time? And now that when that news broke that Africa's vaccination campaign might have just been threatened following that suspension from India concerning AstraZeneca exports, should we worry? How serious, how concerning, what kind of challenge will this pose to our own quest here, given your position about vaccines in Africa?
Well, I mean, this is a big challenge. This is a big problem, and this is what we have been advocating for years. There's no way that you can meet your vaccine needs if you don't produce them locally. Historically, only 1% of all vaccines that are used in Africa are manufactured in Africa. Now, you rightly said that of course, the Indian government banned export of the AstraZeneca vaccine, and that's the only hope that Africa has. And the reason is because there's rising cases of COVID presently in India. And again, the Indian government has to take care of their own people first before they export. Now, if you look at what is currently going on, you find out that in the US, for example, 92 million people have received the first dose. And again, 3 vaccines have been licensed here. And all these doses that are used in this country are manufactured in country. Now, about 48 million people have received their second dose. This is a population of 331 million people. Now, you look at the rest of the world, which is 6.9 billion people, only about 311 million people have received their first dose, and then 120 million people have received their second dose. So indeed, it is a problem. It is sad that we're not even addressing the issue. There's no way. I mean, look at H1N1. It's the same story with COVID-19. Nothing has changed. What stops us from setting up our own manufacturing capabilities to produce vaccines for our people and for the continent? This is not rocket science. It can be done. Later on, I'll tell you the strategies and how this can be done. It's shameful. It is unfortunate that we're still discussing these issues. Now, the Serum Institute, for example, I mean, look at the vaccine nationalism. Indian temporarily banned the export of vaccines. The second vaccine that is supposed to come to Africa, which is from Novavax, which is a US-based company, they licensed the technology to Serum Institute of India. And then because the US invoked Defense Production Act, which gives the president the powers to ban importation of critical raw materials, which is in force, is affecting the production of vaccines by the Serum Institute of India. And as you know, the European Union will not let AstraZeneca export vaccines until the pledge is met. So this is a problem. The 4 million doses that we have in Nigeria right now, my advice would be that you vaccinate only 2 million people and keep the remaining 2 million so that the people that have been vaccinated will be assured that they will get their second dose, because you don't know when the next dose of vaccines will arrive in Nigeria.
They create some chaotic situation now, because since we don't know when the next ones will arrive, and ensuring that just 2 million, what about the fact that I think Lagos trying to work on some other plans to get additional vaccines into the country? Isn't that going to help in any way?
Where are you going to get the vaccine from? It's not about whether you want to get the vaccine or not want to get the vaccine. Where will you get the vaccines from? These are the facts. These are the realities. Even African Union and African CDC has seen that this is a problem, and they are convening a high-level virtual conference on the 12th and the 13th April to discuss how to expand African vaccine manufacturing. This is the only solution that we have. I mean, the intention is not the issue. Wanting to get the vaccine is not the issue. But where are you going to get the vaccine from? This is the issue. You see, I mean, if US, for example, they by May, 1st May, the president said by 1st May, anybody that wants the vaccine will get it. So we're looking at maybe July, August this year, that at least 80% of the 331 million Americans will have been vaccinated. And that will ease, some of these vaccines, and then supplies may improve in other countries. And then if that happens, now, when will it get to us? From the release of the AstraZeneca vaccine that America had, because they have not approved it yet, so they have some stock. You can see they gave it to Mexico and Canada. So if there are excess vaccines, where do you think they will go to? These are the questions that you have to ask them, and look at the position that the EU has taken. And, based on the current vaccination schedule, it will take the EU about 16 months to vaccinate and to reach herd immunity, to vaccinate at least 70% of our population. When will it get to us? The more you allow the virus to circulate in the population, the more they gain, the ability to mutate, and making the current intervention even more difficult.
Dr. Agwale, you're saying some very interesting things now, because the question that comes to mind right now is, what then happens to all the conversation about global equity distribution of the vaccines across various countries? What happens to that coalition?
The truth of the matter is, this is theory. All that is theory. This is practical. No nation, your people will ask you questions. Your people are dying. Infection is going on. And then you are telling the people you are going to export vaccine. Does it make sense to you? So these are facts. You have to look at the facts. It's not about equity, all this theory that we are discussing. These are facts. No nation, no leader, people are dying in that country, infection is going on, and they are telling you the people are not taken care of, and they're going to export vaccine. Does it make sense to anybody? These are facts. You have to look at the facts. It happened during the H1N1. We need to learn from that. And it's happening during COVID. So we need to learn from that, and to know that we need to take our issues very seriously. And that is the reason why AU, African Union and African CDC, is convening this conference on the 12th and 13th to discuss how to expand, because they have seen, everybody has seen clearly that this is the way to go. You have to have the capability to produce these vaccines for your people, not only for this epidemic. If you look at the history of pandemics globally, you know that this is not the last pandemic we're going to face. We're going to have other pandemic, and we don't even know how long the COVID is going to be with us, because there's emergence of new variants today. Now, the problem that that the world we have now is that we have emergence of variants. These variants, some of them have reduced susceptibility, distance to the current vaccines, and some of them have evaded these current vaccines. So new vaccines have to be made targeting these variants. Now, if that is the case, the factories that are producing the vaccines against the original strains will now have to convert to be producing against the variants. You are struggling to still get the first, the first generation vaccine that is based on the original strain. When will you have the opportunity to have the second strain? So this is the problem. This is what we need to address. This is the fact.
What happens if, because this is a scenario that might likely play out, where those who have taken the first jab here in the country may not have the opportunity to go for the second, or to even take the second jab because it may not be available when that time, when it's time, if we don't act early and say, listen, okay, well, look, let's just restrict it to 2 million as opposed to going ahead to the 4 million, because chances are that we may not act as fast as perhaps you're suggesting. What will happen to those category of people?
This is the problem, and this is why this program is very important. The government needs to know that the 4 million doses that we have now should be for 2 million people. Keep 2 million doses so that those that have taken the first dose will have their second dose. Don't go ahead to vaccinate 4 million people because you don't know when you're going to get the second dose. It's risky to do that. Now, the fact of the matter is that apart from the AstraZeneca vaccine, like I said, the Novavax licensed that technology to Serum Institute of India. Now, why is everybody going to Serum Institute of India? They are the largest vaccine manufacturers on earth. You are talking about intellectual property. Nobody, even if you take out intellectual property today, can the vaccine be produced in Africa? There's no capacity. So now Novavax, outside, apart from the AstraZeneca, licensed the technology to Serum Institute to produce for the rest of the world. Now, Serum Institute CEO came out to say that we will launch that vaccine in September because they have to figure out how to produce, do all the clinical trials and so on. So by September, October, that product will be launched. So nobody, you have to have the capacity before anybody will license the technology to you. It's no capacity.
So
you don't
what would you advise, for instance, now there may be those listening saying, look, I've taken the first jab. Now, I don't even know if I'm going to have an opportunity to get the second jab. While others will think, wait a minute, if this is the scenario, why should I even go for the first jab if I don't know if I'm going to get a second jab? What would you tell this category of people?
Well, studies have shown that one dose of the AstraZeneca vaccine has efficacy of more than 70%. But that is not to encourage people to take only one dose, because based on clinical trials and based on the protocol that the company has, you have to take second dose, because if you take the second dose, it increases the efficacy to about 80-something%. So this thing has to do with the government policy, because if you know, and the company that produced the vaccine is telling you that you need 2 doses, keep the remaining 2 doses, vaccinate 2 million people so that these 2 million people will be assured that they will get their second dose.
So, there's a challenge here for me, and I'm hoping that for those listening, especially those who have gotten the first jab or those who are meant to get it today, they don't get alarmed and start panicking. So from what I've heard, the first dose or the second dose should be taken about 3 months after the first dose. So if we're in, let's say April.
12 weeks, yes.
12 weeks. So if we're in April, that's April, May, June. So I'm thinking June. And, listening to India saying that we have supplied way more vaccines than we have even vaccinated our people. Imagine supplying about 60 million and vaccinating just 50 million of their people. So it sounded like we need to at least measure up. So this sounded like a temporary measure, not a permanent measure. And for some, they say if the first dose or the first jab gives you 76%, the second jab just over 80%. Isn't that fair enough? So the challenge here is not to maybe get people alarmed. Don't you think it's fair to at least vaccinate 2% of our population with the 4 million doses, as opposed to just vaccinating 1% of our population with 2 million, and then they get the second jab? I believe you understand what I'm saying. If we're saying the more the merrier, we're trying to reach herd immunity, isn't it better to get 2% at least to get the first jab and get 76% protection as opposed to just 1%?
Nobody is going to encourage you to do that because science is based on data. Of course, I mean, it was even based on data that we came up with the 12 weeks scenario. So it's possible that one dose. This is why we need to encourage our universities and research institutes to do research, because we have these products in the country. If we have data to back what you have said, then we'll go ahead and implement it. But this is not theory. I mean, we can't sit down here and predict, and assume that this is what is going to happen. You have to do this research, and then let science dictate, the protocol that we adopt. What you said, fantastic. I mean, great ideas, but it has to be backed by science.
I think the CBN has allocated some funds for some researchers to ensure that, yes, we get in that way of ensuring that we develop capacity here. You were going to talk about how to do that. Please go ahead on that.
Well, I mean, the CBN thing, the people they gave the grants to, initial grants to, the topics of their projects were not published, so I don't even know, what they set out to address. The truth is that there's no vaccine development manufacturing program in country. So what we have decided to do, living in the two worlds, is to come up with a strategy of bringing international vaccine manufacturing expertise to Nigeria and in Africa. And what is the strategy? You tap from the resources that are here in the US, do all the R&D, do the process scale up, and then build a facility, down there in Nigeria, and then make initial doses of the vaccines here in the US for clinical trials, and then for implementation. So that is the fastest strategy that is going to work, because you don't have the capacity there right now to produce the vaccine, develop the vaccine. So we take advantage of what we have. So right now, the issue that we will have is the second generation vaccine, because all the vaccines that we have now are based on first generation vaccines, and there's no guarantee that they will protect against the new variants. So already we are working on the South African strain, and then the Brazilian strain, the UK strain. So you have a multivalent vaccine that will protect against all the variants. So this work is ongoing. Big news probably in June. You hear the outcome of that data. Initial doses are going to be made here, and then while the doses are going to be made by contract manufacturers here, we'll be busy developing infrastructure in Nigeria to produce that vaccine so that we'll be self-sufficient, not only self-sufficient, but with the best products globally. So that is where we're going. And all we need is the government support, creating the necessary environment, engage us, we discuss, and then we solve this problem.
Doctor, I'm just hoping there would not be an order at that time halting export of that vaccine, because, I mean, things change, right? But earlier on in this conversation, you said that, Africa only produces 1% of the vaccine it uses on the continent. So that's to say, at least there's some capacity, even if it's 1%. So which countries are positioned, really, to at least lead in vaccine production?
Good question. Well, I mean, we have made it clear that the program that we have here in the U.S. is Africa-centric. So you won't have those issues that you raise. It's Africa-centric. That's the goal. Now, the 1% is coming from Senegal. Senegal is the only country on the continent that has end-to-end. That means they produce the antigen, that's yellow fever vaccine, and then they do the fill and finish. So the capacity that they have now is not even enough to meet WHO demand, because they are producing just about 7 million doses of yellow fever vaccine per annum. They are building a new factory that will produce 15 million doses of the vaccine per annum, and all that will be yellow fever. So we're not talking about other vaccines. I mean, 15 million is a drop in the ocean. In fact, you can't even take care of Senegal with that dose. The second company is BioVac in South Africa. Now, BioVac capacity is for fill and finish. So they partner with Sanofi, other companies, to do fill and finish. The capacity that they have right now is just 25 million doses of vaccine per annum. Even if they stop what they are doing to do fill and finish for COVID, all that we produce will be 25 million doses of the vaccine per annum. You have Pasteur Institute in Tunisia that is producing only 100,000 doses of the DTB-based vaccines, and then you have Vaxera in Egypt, which is producing only about 100,000. That's the capacity that you have. That's the only capacity you have in Africa, which is a drop in the ocean. And that is why the African Union and African CDC have seen the need. We need to expand this. There's no way, because you have your money now, you can't even get the product. So what is the solution? Why can't we build this capacity locally? And at the end of the day, it's the companies, the individual companies that will make this happen. So Nigeria is in the best position because you have the best scientists on the continent that will make this happen. All you need to do is to engage with this and then lead Africa in this effort. And then we can now bring in this needed knowledge-based economy to the country.
Okay, Dr. Agwale.
It's a little disconcerting what you said when about our capacity in Africa. A little more troubling, perhaps, because going back in time, we find out that Nigeria had tremendous capacity to produce vaccines over the years, and this, if the institutions and infrastructure were strong enough to sustain. That had been sustained over time, this would be a no-brainer, one would suspect. However, just recently, the chairman of the PTF COVID-19 in Nigeria announced that Nigeria has produced 2 vaccines for COVID-19 awaiting trial and certification. Is that any comfort in the argument you were making about Nigeria producing vaccines locally?
I got all kinds of emails and messages regarding that. When this announcement was made, they did not publish the names and the institutions where these things were done. Vaccine development manufacturing is not rocket science, but it's not a trivial issue. Currently, There's no capacity. I can tell you, with all confidence that there's no capacity right now in the country to produce, develop, and produce vaccines. These are not things that you just wake up overnight and you want to do. And we have to be careful the kind of information that we send, because we become a laughing stock globally. When you say, vaccines are developed in Nigeria, the world knows how vaccines are developed and the infrastructure you need to develop vaccines. So where are the vaccines? Where are the institutions?
Just 1 second, Dr. Agwale. When you say we do not have capacity, could you please explain what you mean? Because I would assume that we have the personnel. So, and I would assume that we have the brains. At least you are a Nigerian as well. So clearly one can say that the mental capacity, the scientific capacity is there. So what is the shortfall?
This is the thing. I mean, why am I here in the US working on COVID vaccine? Because there's no capacity in country to do that. I mean, what is the capacity for, what does it entail to develop a vaccine? The first is you have to have a standard tissue culture laboratory with 24-hour power. That's first. When you make the vaccine, you have to test it in animal. And this animal facility has to be according to what we call good laboratory practices. There's no single animal facility in Nigeria that is operating according to good laboratory practices. So when you finish the animal studies, you have to produce the initial dose for human trials, and that has to be done according to good manufacturing practices. There is no single factory in Nigeria that is producing vaccine according to good manufacturing practices. Now, before you even manufacture that, you have to talk about doing clinical trials under good clinical practices. There is no platform in the country right now that does clinical trials according to good clinical practices standard. This is basically what we're talking about. So this facility, this infrastructure, this whole thing has to be built. And it's not rocket science. It can be done. All we need is to engage, discuss, how can we make this happen? You have the Nigerian Medical Research Institute, you have the National Institute for Pharmaceutical Research, you have some universities. So this can be done, but currently, none of these things exist. So you cannot make a vaccine in Nigeria and say, you have made this vaccine, let the world accept it. No, it cannot be done. That's why we are here using this standard to produce this, and then we do backward integration, so that we take that. That's why I said that bringing international vaccine manufacturing expertise in Nigeria. This vaccine, whatever you produce in Nigeria, is not only for Nigerians. It's going to be used throughout Africa and throughout the world. So you have to abide by all the necessary standards, global standards that are in place.
Okay, Doctor, let me see if I can lump this last question together, because, I mean, seeing the things you reeled out, standard tissue culture laboratory with 24-hour power supply, and that list goes on and on. I mean, that's going to be a big deal. But so as we wind down, how much funds would we need to put in place if we want to achieve this? And now the time factor, how long would it take to at least get some measure of, capacity put in place? And who should take the lead? That's 3 questions, I know, but let's see if we can lump them together.
Good question. Private sector has to take the lead. That's why we're here. By private sector. If you look at all the vaccines, I mean, the companies that are producing COVID vaccines, they're all private initiative. But the government has to provide the enabling environment for this to be achieved. Now, for you to set up an end-to-end facility to produce at least 200, 300, 400 million doses of vaccine per annum, you are talking about $50, $60 million to make that happen, which is just a drop in the ocean based on the impact of the COVID. So Kakovic, CBN, they can create initiative or platform or some kind of soft funding arrangement, which is done globally. I mean, the reason you have the COVID vaccine that we're talking about now, a record time, this is the first time that you're developing vaccine in less than 1 year. Previously, it takes about 10, 15 years to develop a vaccine. Why? Because there was serious government intervention. Government intervened in the big companies, giving companies grants, advanced purchase commitment, all kinds of gymnastics to make sure that these vaccines are made. This is what I expect from the Nigerian government. The African Vaccine Manufacturing Initiative is the place to go. They tell you who is doing what on the continent. And then the Nigerian government need to engage with the right partners in the country and bring them on board and say, okay, what do you need? How can we make this happen? You go out of your way to make this thing happen. You can't sit down and expect a miracle to happen. If that is the case, we wouldn't have had the COVID vaccine today.
What about the time frame? The time frame. When is the shortest possible time?
Now, the reason that it will take us just about 18 months to get to the destination is because we have been in this game for years. If you want to start today, it will take you about at least 4 years, 5 years to set up a factory. But we have developed all the processes that are needed. We have the candidate vaccines, not only COVID, we have candidate vaccines for Ebola, HIV, and so on. So if we have all the support that we need, in 18 months, sometimes next year, we will domesticate the expertise for producing vaccines, and not just vaccines, but state-of-the-art, latest technology vaccines in Nigeria for Africa.
All right, then, Dr. Simon Agwale, Chair, Africa COVID-19 Vaccine Manufacturing Initiative. Thank you very much indeed for your time this morning.
Thank you.